Hi everyone, we'll be starting in a few minutes. I am Twin Tran, APCHO's Training and Technical Assistance Director. On behalf of APCHO, I welcome you to today's webinar on diabetes in Asian Americans, the need to screen at 23. APCHO is a national association of 35 community health organizations dedicated to promoting advocacy, collaboration, and leadership that improves the health status and access of Asian Americans, Native Hawaiians, and Pacific Islanders. We are also a Bureau of Primary Health Care Training and Technical Assistance National Cooperative Agreement holder, funded to provide training and technical assistance that is data-driven, cutting edge, and focus on quality and operational improvement to support health centers, lookalikes, and newly funded HRSA awardees in caring for Asian Americans, Native Hawaiians, and other Pacific Islanders. For today's webinar, according to recent estimates from the CDC, diabetes affects more than 30 million Americans in the U.S. When compared to African Americans, Caucasians, and Hispanics, diabetes prevalence for Asian Americans ranked the highest. During this session, our three speakers will discuss the efforts around diabetes prevention for Asian Americans, Native Hawaiians, and Pacific Islanders, the research behind the need to screen at BMI 23 for Asian Americans, and resources available to support your health centers and patients in diabetes screening and prevention. Our agenda will include a 45-minute presentation with a question and answer immediately following. But before we get started, I want to review a few housekeeping items and let you know how you can participate in today's webinar. Here we are looking at an example of the GoToWebinar attendee interface, which is made up of two parts, the viewer window and the control panel window. The viewer window allows you to see everything the presenter will share on their screen. The control panel window allows you to participate in the webinar. By clicking on the orange arrow button, you can hide or show your control panel. Please note that all attendees are in listen-only mode and will be muted during the webinar. You may submit questions during the presentation portion by typing them in the questions field of your control panel. We will be reviewing questions as they come in, but we'll address them during the Q&A portion of our session. Today's webinar is being recorded, and you will receive an email with a link to view the recording after the webinar. Our first speaker is Jeff Caballero. Jeff is APCHR's executive director and has been with APCHR since 1993. Mr. Caballero advocates for programs and policies that increase access to high-quality, comprehensive healthcare services that are culturally and linguistically appropriate. Mr. Caballero also participates in national committees addressing disparity issues affecting Asian Americans, Native Hawaiians, and Pacific Islanders, such as tuberculosis, hepatitis B, diabetes, and cancer. Currently, Mr. Caballero is serving as founding co-chair of Hep B United and chair of the American Diabetes Association's Legislative and Regulatory Subcommittee, as well as member of the ADA's Asian Pacific Diabetes Action Council. And Jeff, thanks for being here with us today. Go ahead.
Thank you, Twin. Thank you very much for the introduction, and thank you for the opportunity for APCHR just to provide a quick background on this very important new policy that's currently being implemented nationally. I have to begin my background by first acknowledging the National Council of Asian Pacific Islander Physicians, or NCAPEP, who is a very important APCHR partner in this effort, as well as recognizing the Asian American, Native Hawaiian, Pacific Islander Diabetes Coalition, of which APCHR is a partner of, who is also very critical and vital to this particular effort. And I just wanted to also share my appreciation and acknowledge Dr. Happy Araneta, who is on the phone with us as a representative of the Diabetes Coalition and a friend. So to begin my background, I just wanted to provide a reference that prior to 2000, as a national advocacy organization, APCHR predominantly just focused on promoting the collection of disaggregated data and translating patient education materials for diabetes. But in 2000, I had Dr. Will Fujimoto, who I consider is the godfather of Asian American Pacific Islander diabetes, provide APCHR with a very important education regarding WHO Western Region report about how Asian Americans and Native Hawaiians and Pacific Islanders are different with regards to diabetes risk. I have to also just interrupt myself here for a second and just to remind folks that the reason that I'm providing this history is that I believe is that it's important for us to appreciate where we are now. And we can't do that unless we know how we got here, so that we can together continue to advance an agenda to reduce diabetes prevalence and its devastating complications in our Asian American, Native Hawaiian, Pacific Islander communities. After Dr. Fujimoto's introduction to diabetes disparities, I have to also recognize that it was in the mid-2000s that I believe it was in the mid-2000s that the American Diabetes Association took a leadership role in engaging AA and HPI communities and convened an Asian American Pacific Islander Diabetes Action Council. This was critical in helping to develop and elevate a national diabetes agenda. The discussions with the American Diabetes Association was critical in a 2011 convening held in Honolulu, Hawaii, in which the NCAPEP leadership and the American Diabetes Association leadership convened a call to action, diabetes and Asian American, Native Hawaiian, Pacific Islander communities. This call to action in Hawaii was critical in launching the AA and HPI Diabetes Council that I acknowledged earlier, but perhaps equally as important, it catalyzed an academic and clinical leadership focus that was necessary to elevate the evidence base needed to support our current diabetes agenda today. Which brings us to 2015, a hallmark moment when the American Diabetes Association released the updated diabetes care guidelines, recognizing the Screen at 23 program, redefining the standard of care for screening Asian Americans. As an advocate, I had to just pause for a second and note that Dr. Happy Araneta recently reminded me that in this January, it will be the 3-year anniversary of Screen at 23. It made me realize that we must do more to help providers and organizations recognize the importance of when to screen Asian Americans for diabetes. Lastly, I want to draw your attention to your webinar handout. You should have received a copy of the recently launched AA-NHPI Diabetes Coalition Action Plan, which includes unique research priorities for those Asian Americans, as well as for Native Hawaiians and Pacific Islanders. And other priorities, which I just want to highlight, include a recommendation to screen Native Hawaiians and Pacific Islanders at the age of 18. So with that as a background, I hope that helps in some context, and I transfer the webinar back to you, Trent.
All right, thank you, Jeff. And again, if you have any questions for Jeff, feel free to enter them into the questions panel on your end, and we will be addressing all the questions towards the end of our webinar today. So our next speaker is Happy Araneta. Dr. Araneta is the principal investigator of the UCSD Filipino Health Study, co-investigator of the Rancho Bernardo study, where she leads health disparities research among Caucasians, Filipinos, and African Americans. She's also the co-principal investigator of the multi-site diabetes prevention program outcome study at UCSD. Dr. Araneta is also the academic partner to Operation Samahan Health Clinic's community interventions funded by the CDC to enhance availability of healthy dining options in Asian and Pacific Islander restaurants, grocery stores, and farmers markets, as well as their National Diabetes Prevention Program. Dr. Araneta co-authored the American Diabetes Association position statement to revise diabetes screening guidelines amongst Asian Americans. Dr. Araneta received the 2014 American Diabetes Association's Vivian Fonseca Award for her research on diabetes among Asians and Pacific Islanders, and received the Best in Care recognition for authoring one of the 9 most noteworthy articles published in Diabetes Care in 2015. She also serves on the American Diabetes Association's Scientific Sessions Epidemiology Subcommittee. And today she will be talking about the data behind the new diabetes screening guidelines for Asian Americans. But before we get to that, we have a poll for you. And Nicole, if you could launch that for us. Okay, all right. So thank you for participating in this quick poll. We're now going to end it, and we'll have Dr. Araneta speak.
Thank you and good afternoon. The American Diabetes Association recommends diabetes screening for adults aged 45 years and older who are overweight with at least one diabetes risk factor, shown in the yellow box, and includes belonging to a high-risk racial or ethnic group, such as Asian or Pacific Islanders. In January of 2015, the ADA revised the screening guidelines by lowering the BMI cut point of 25 kilograms per meter squared in all ethnic groups to 23 for Asian Americans. California is ethnically diverse, where 63% are ethnic minorities, and is home to the largest Asian Pacific Islander population. Data from 2 million members of Kaiser Permanente hospitals show diabetes prevalence was highest among Pacific Islanders, Filipinos, and South Asians, and they had higher prevalence compared to Latinos, African Americans, and Native Americans, groups perceived to be at highest risk for diabetes. You'll notice that Japanese, Vietnamese, and other Asians also had higher diabetes prevalence compared to whites. This graph demonstrates the importance of disaggregating Asian and Pacific Islander subgroups. Diabetes incidence appears similar among African Americans and Latinos compared to all Asians and Pacific Islanders when reported collectively and circled in red. However, once disaggregated, Pacific Islanders, South Asians, and Filipinos have higher diabetes incidence compared to all other ethnic groups in a population with similar access to healthcare. The orange line represents a BMI of 30, a marker for clinical obesity. Whites, Blacks, Latinos, Native Americans, and Pacific Islanders with incident diabetes in gray, that middle column, and diabetes prevalence in white, and even some non-diabetics in the black columns, all had a mean BMI above this orange obesity line, whereas the mean BMI of Chinese, Japanese, Filipinos, and South Asians with either newly diagnosed or prevalent diabetes were below this orange obesity line. Several studies have shown that Asians, such as Dr. Yajnik on your right with a beard, had significantly more body fat compared to whites of similar BMI. Both gentlemen have a BMI of 22, but the South Asian man has twice the body fat, 21 versus 9%. Visceral adipose tissue is an active endocrine organ which releases cytokines that have an important role in glucose homeostasis. This CT image shows a 6 millimeter slice between the L4 and L5 vertebrae. The overweight African American woman on your left has 25 cubic centimeters of visceral adipose tissue shown in red, while the Filipino American woman on your right with a BMI of 20 at 5'4", 115 pounds with a 26-inch waistline has 84 cubic centimeters of visceral adipose tissue, 3 times the volume of the overweight African American woman. Such excess visceral fat accumulation has also been reported in South Asian, Japanese, and Korean populations. Before 2015, ADA guidelines suggested screening for type 2 diabetes should be considered in asymptomatic adults ages 45 years and older with a BMI of 25 or higher with at least one known diabetes risk factor. However, Asian Americans manifest diabetes at lower BMIs and might not be screened. Our objective, therefore, was to identify the optimum BMI cut points for diabetes screening among Asian American adults. We searched the medical literature and identified just 4 clinical studies which performed an oral glucose tolerance test to ascertain type 2 diabetes in Asian Americans. They included the University of California, San Diego Filipino Health Study, the North Kohala Study in the Big Island of Hawaii, the Masala Study in San Francisco and Chicago, and the Seattle Japanese Diabetes Community Study. Participants reported race and ethnicity and had no non-Asian admixture and no prior diagnosis of diabetes. All had measures of BMI and fasting and 2-hour glucose values from the OGTT. Glycosylated hemoglobin was available from all sites except for Filipino men in San Diego and Japanese participants in Seattle. Type 2 diabetes was defined as A1C levels of 6.5% or higher, or fasting glucose after a minimum 8-hour fast of 126 milligrams per deciliter or higher, or a 2-hour post-challenge glucose level of 200 milligrams per deciliter or higher. Statistical analyses included receiver operating characteristic curve analysis, calculations of sensitivity, specificity, and positive predictive value, and selection of optimal BMI cut points included reviewing Uden's index values, misclassification rates, the BMI cut point where sensitivity was equal to specificity, and a practical targeted sensitivity of 80%. Among our 1,663 participants, 58% were women, 1/3 were Filipino, 37% were South Asian, and 30% were Japanese. The mean age was 59.7 years, and mean BMI was 25.4 kilograms per meter squared. The age-adjusted prevalence of type 2 diabetes was almost 17% and was highest among Filipinos at 22.8% compared to 13% among Japanese and South Asians. Among the 1,200 participants with all three glucose measures, age-adjusted diabetes prevalence was 18%. Half had A1C levels greater than 6.5%, and only 5.5% had fasting hyperglycemia, but the majority, 15.5%, had post-challenge glucose levels exceeding 200 milligrams per deciliter. This means that if screening is limited to just the A1C and fasting glucose measures only, almost half, or 44% of Asian Americans with diabetes, those with isolated post-challenge hyperglycemia, that is, normal A1C, normal fasting glucose, but an elevated 2-hour post-challenge glucose, might remain undiagnosed without an OGTT test. The mean BMI at the time of diabetes diagnosis was 26.7. However, 37% of women and 21% of men on the left side of the yellow arrow had BMIs less than 25. Some even had BMIs as low as 16. A woman who was 5'4" and just 93 pounds at the time she was diagnosed with diabetes. If screening was limited to a BMI greater than 25, the sensitivity is just 64%, which suggests that 1/3, these 102 of the 281 with diabetes, might remain undiagnosed since their BMI is less than 25. The sensitivity ranged from 85 to 36%, even though the misclassification rate was similar across BMI cut points. The sensitivity and specificity approached each other at a BMI of 25, but as shown in the previous slide, would fail to diagnose 1/3 of Asian Americans with diabetes. When using Uden's index, you see that the Uden's index values, shown in burgundy, are similar and similarly low across all BMI cut points. But at a BMI of 23, the sensitivity is at least 80% or higher for all the Asian subgroups. Since the misclassification rate and Uden's index values were similar across BMI cut points, we used a targeted sensitivity of 80% and identified an optimum BMI cut point of 23.5, which applied to the total population by gender, as well as among Filipinos and South Asians, and a cut point of a BMI of 22.8 among Japanese Americans. When stratified by diabetes diagnosis, the optimal BMI cut point ranged from 24 for those diagnosed with diabetes by glycosylated hemoglobin to 23.2 for those with post-challenge glucose levels above 200. The old guidelines of screening at a BMI of 25 may fail to identify 1 of every 3 Asian Americans with diabetes. A BMI cut point of 23 kilograms per meter squared may be most practical for diabetes screening in Asian Americans. However, limiting screening to glycosylated hemoglobin and fasting plasma glucose measures may fail to identify almost half of Asian Americans with diabetes, reiterating the importance of OGTT measures. Doctors Will Shu, Alka Kanea, Jane Chang, Will Fujimoto, and I were delighted to write this position statement for the ADA and hope that the new screening guidelines facilitate early diagnosis and management of type 2 diabetes and reinforces awareness of ethnic differences in the pathophysiology of type 2 diabetes. The strengths of this analysis include population and community-based samples, and diabetes was ascertained by glycosylated hemoglobin and OGTT. However, our data is not representative of all Asian Americans. Finally, data to inform these new guidelines would not have been possible without the commitment of our study participants, our communities, research teams, and multiple funding agencies. Thank you. Good afternoon. Before we proceed to the question and answer section, I'd like to introduce this educational video, which was prepared by Brian Nguyen, a third-year medical student at UCSD. And his goal was to reach out to the large number of Asian American students. We have 10,000 Asian American students on the UCSD campus. And Brian's goal was to produce a 5-minute video that all 10,000 students can view so that they can take their parents and grandparents for a diabetes screen. So we hope this resource is useful to you if you have college or graduate age students, and this also might be useful to show in your clinics.
Type 2 diabetes is a progressive disease caused by problems with insulin secretion and action. 1 in 6 Asian Americans have type 2 diabetes, and half of those affected do not even know they have it. This video will explore the reasons behind the revised screening guidelines for diabetes in the Asian American population. Let us begin by looking at 2 people from different ethnic backgrounds. An African American woman with a height of 5'3", about 1.6 meters, and 145 pounds, about 66 kilograms. If we calculate her BMI, it would be BMI of 25. BMI stands for body mass index, and the BMI is used as an approximate measure of whether someone is over or underweight. 25 is just borderline overweight. The second woman is an Asian American Filipino with a height same of 5'3", about 1.6 meters, and 130 pounds, which is about 59 kilograms. She has a BMI of 23. Which person do you think is at a higher risk of diabetes? If you said the Filipino Asian American woman, you are correct. And this video will explain why, despite her slimmer appearance and lower BMI, she is at a higher risk. Now, diabetes is a chronic illness where there are high amounts of sugar, also known as glucose, in the blood. The risk factors for developing diabetes include a sedentary lifestyle, obesity, gestational diabetes, hypertension, high cholesterol, vascular disease, and family history of diabetes. In the long term, as a result of persistent high blood glucose in the blood, diabetes can cause many deadly and disabling complications, including eye disease, cardiovascular disease, kidney disease, and diabetic foot. These complications in turn can lead to blindness, heart attack or stroke, end-stage kidney disease, and amputation of limbs. Therefore, screening for and treating this chronic disease is paramount. Current American Diabetes Association guidelines for the generalized population is if someone has a BMI equal to or greater than 25, plus having at least one of the risk factors mentioned previously. BMI is one way of measuring whether someone is overweight. However, it has its flaws. Someone can be super muscly and have a high BMI, and some ethnic groups, as we have seen, can have a low BMI but still have a high risk of diabetes. Although flawed, it is still valuable in giving the clinician a snapshot in short clinical visits. A landmark study in California conducted by Carter and colleagues looked at the prevalence of diabetes in different ethnic groups. They showed soaring prevalence of diabetes amongst Pacific Islanders, about 18%, Filipinos, about 16%, and South Asians, about 16%, when compared to racial and ethnic groups traditionally attributed with diabetic risk factors, such as Latinos, 14%, African Americans, 14%, and Native Americans, about 13%. As you can see, the Asian population has a relatively high prevalence of diabetes. However, the measured BMI was consistently lower. Simply put, Filipinos and specific groups of Asian Americans had higher rates of diabetes, even though they were not obese, according to the BMI. This 2013 study showed the concern that non-obese Asians have high rates of diabetes and might be undiagnosed. This is where the study of fat distribution comes in. Prior American Diabetes Association guidelines were generalized and did not take in ethnic variability and fat distribution. If we take a cross-section of the tummy, it shows the relative difference in size straight away. This African American woman may have a lot of peripheral fat, which is the fat that can easily be seen under the skin. But she has low central fat, fat which surrounds the organs, which is not visible by the naked eye, as depicted in yellow here. Whereas the Asian American woman may have less peripheral fat, but much higher central fat concentrations, up to 3 times the amount. This means that a falsely deflated Asian American BMI can be hiding central adiposity, which is indicative of diabetic risk. Thus, Filipinos and other Asians, including Japanese, Koreans, South Asians, and Chinese, also have more central fat than African Americans. Therefore, the American Diabetes Association decided to lower the BMI from 25 to 23, plus risk factors, to catch the Asian Americans who is normal appearing, normal weight, but metabolically obese. Remember, in the general population, people with a BMI of 25 or greater with risk factors is the group screened for diabetes. With the new American Diabetes Association guidelines, people with a BMI of 23 or greater are screened in order to catch the Asian Americans who may have a lower BMI but at a higher risk of diabetes. Furthermore, after the update, a study by Menk and colleagues in the Journal of the American Medical Association noted that 50.9% of Asian Americans living with type 2 diabetes remain undiagnosed. This study tells us that many Asian Americans do not know they have diabetes and supports the need to screen the Asian Americans for diabetes, especially if they have risk factors. It is important to act now if you or your family members have a BMI equal to or greater than 23, are older than 45, and have risk factors. Get tested or schedule your parents, aunts, uncles, and all your loved ones for a diabetes test today. If you would like to participate in our study to measure the effects of this video, there is a link to participate below that will take you to a very short 2-minute survey with a 3-month 2-minute follow-up via email. This video was made as part of a study conducted by Brian Nguyen from the University of California, San Diego School of Medicine, with the support by the National Medical Fellowship. We would also like to thank our partners.
Okay, and now we just have a second poll question that we're going to launch for you. If you could just please participate. Go ahead, Nicole. Okay, thank you for your participation in that quick poll. Our final speaker for the webinar is Jen Reeves. Jen is APCHA's Director of Community Services and Partnerships. She is the Director of APCHA's Bureau of Primary Health Care National Cooperative Agreement, providing technical assistance and training for Asian American, Native Hawaiian, Pacific Islanders serving community health centers nationally, the development of new community health centers, and APCHA's CDC-funded diabetes prevention program. Prior to joining APCHA, she spent 14 years in a federally qualified community health center, Asian Health Services, based in Oakland, California, providing operational oversight of eligibility and enrollment, community outreach, translation, and medical interpreter certification and advocacy initiatives. Jen?
Thank you, Twin. So I just wanted to take a few additional minutes today to share about a few other efforts that APCHA is engaged in to continue to uphold effective strategies, interventions addressing diabetes, in addition to our Screen at 23 focus today. For those of you who are listening in, who are from a health center or perhaps a primary care association or even a health center control network, we wanted to offer and let you know that APCHA is hosting and participating in a national webinar series that you're welcome to sign up for. And this is hosted in part through our cooperative agreement with the Bureau of Primary Health Care. It's the National Diabetes Task Force for Special and Vulnerable Populations. And the webinar series is going to be addressing the unique needs of special and vulnerable populations with diabetes. So by special and vulnerable populations, we mean individuals experiencing homelessness or unstable housing, migratory and seasonal agricultural workers, school-age children, in addition to Asian Americans, Native Hawaiians, and Pacific Islanders. APTO is also hosting a learning community for health centers serving Pacific Islander populations. So as you've heard from our speakers today, Pacific Islanders do experience one of the highest prevalence rates of type 2 diabetes. So our learning series for Pacific Islanders serving health centers will focus on issues such as motivational interviewing, medication adherence, and other approaches effective in working to manage diabetes for Pacific Islander populations. So highly encourage you all to look out for our promotion and enrollment for those two learning communities. And lastly, just as Twin mentioned, I wanted to share that our organization is a CDC cooperative agreement holder, and we're currently working to support the expansion of certified diabetes prevention programming in the Pacific Island jurisdictions, as well as amongst mainland serving health centers working with Pacific Islander communities. So we're very honored to be a part of that project, and would encourage you all to contact myself or Twin Tran for more information about all these opportunities, and please enroll in APTO's listserv as well. It's a great way to stay tuned for all these resources coming up. Thank you.
Okay. Thank you, Jen. If you have any questions, please continue to enter them into the questions box, and we will be addressing questions in the order that they came in. Just to make a shameless, not so shameless plug, we at APTO are partnering with Migrant Clinicians Network, but really on behalf of all the NCAs that are part of the Special and Vulnerable Populations Diabetes Task Force. We'll be holding a webinar on our sort of current national efforts on helping health centers, PCAs, and networks address diabetes for their patients. And the kickoff is on November 29th at 11 a.m. PST. We will not be holding any 11 p.m. calls. But at 11 a.m. PST, here below on the link is the registration link on the slide, and we will be sending out the slide deck after the end of our webinar today. So you'll receive all the slides as well as the recording and the registration link for this upcoming webinar. So please continue to send in your questions. The first question that I have is for Dr. Araneta. How many new Asian Americans might be diagnosed with diabetes if the new guidelines are fully implemented?
Thank you for that question. We estimate that there are 21 million Asian Americans, and if you assume half of them are over the age of 45 and about 17% have diabetes, we estimate that about 1.7 million Asian Americans have diabetes, and of those, half or 51% will remain undiagnosed. So that's 500,000 Asian Americans who are undiagnosed. And if you screen them at a BMI of 23, we might capture 300,000. So the answer is 300,000, but that still leaves about 200,000 Asian Americans whose BMIs are less than 23, including the case that I referred to, the woman who was 5'4" and 93 pounds when she was diagnosed with diabetes in our collective cohort.
Okay, thank you. Yes, I should be screening. I should both get screened as well. So does the campaign Screen at 23 target patients or physicians or both? And Dr. Araneta, you can answer this question as well as Jeff, who's been part of the coalition as well.
I think the Screen at 23 campaign was started by NCAPIP, and so the goal was to target providers, but I think we should all be responsible for our own health care and take a proactive role in seeking testing. And if our providers are not aware about the new guidelines, then we as members of the Asian American community should inform our providers and inform our communities that we need to get tested. I think a big issue is getting the Asian American population to acknowledge that they could be at risk. because it conflicts with the messages in the general population that only obese people are at risk for diabetes.
And from APCHO's end, I just have to acknowledge that our current efforts around Screen at 23 has really been provider or organization oriented. We have not yet done any type of outreach or education efforts targeted towards patients. But that may change given that we're starting to do some diabetes prevention programming. But right now, I just wanted to acknowledge that our current efforts are all provider oriented.
I also wanted to add that part of the reason why Brian Nguyen, our medical student, was interested in developing this 5-minute video was that in recognition that as immigrants or as children of immigrants, we often serve as the language interpreters or even the health results interpreters of our parents and grandparents. And so his video was intended for college-age students to be aware of our elevated risk and to take the initiative to take their parents and other relatives for a diabetes screen.
Okay. Thank you, Dr. Arnetta, and thank you, Jeff. The follow-up question is, what are the consequences if Asian Americans are not screened for diabetes?
The consequences for having undiagnosed diabetes for Asian Americans are similar to everyone else who has undiagnosed diabetes, and that is they could manifest complications such as cardiovascular disease, kidney disease, blindness. Retinopathy is a common consequence of untreated or undiagnosed diabetes and is the leading cause of blindness in adults. I'd like to share a story of why we started studying diabetes in Filipinos here, and that's because our department chair at the time noticed that the majority of patients at the Veterans Administration Hospital next door to us who were patients in the dialysis units were thin Filipino men. And she was baffled that they were thin, they were in the Navy, they had access to health care, they exercised often, they had to keep their weight down as part of the Navy requirement. And the question was, were they diagnosed late? Were they even screened at all because they were not obese, such that the only time that their risk for diabetes was recognized was when they started experiencing kidney failure.
Thank you for sharing that story, Dr. Arnetta. The next question is, I think if Jeff or perhaps you, Dr. Arnetta, or Jen can address this, is there any funding opportunities for diabetes in the Asian American populations that you're aware of?
Nationally, the only diabetes-related funding that I'm aware of has been the diabetes prevention program for underserved populations that, as Jen reported, we were recently just funded in. I'm not sure of any other type of unique funding that is available. However, I just want to note that Screen at 23 is the current standard of care and is currently reimbursable through Medicare and Medicaid, and as well as a number of different health plans as well.
Okay. Thank you, Jeff.
Jeff, I'm glad you mentioned the NDPP, the National Diabetes Prevention Program, which was based on this large national study called the Diabetes Prevention Program, which was implemented in 26 universities and hospitals in the U.S., which showed that lifestyle modification, that is exercising, making healthy eating decisions and losing just 7% of your weight was more effective in reducing diabetes incidence. It was more effective in going from pre-diabetes to diabetes compared to a drug, compared to metformin. So this lifestyle modification is cheaper, and it was just as effective among the Asian American participants and Pacific Islanders in the national DPP study compared to all other ethnic groups. And so as a result of that, CDC started these NDPP, the National Diabetes Prevention Programs, and I'm pleased that APCHO is leading the effort with the Pacific Islander community. We've implemented that in one of the federally qualified health centers here in San Diego, where 70% of the patients are Asian. However, when we started the NDPP program in August, there was only one Asian participant, and he dropped out after 2 weeks. So participation in interventions in clinical studies is a challenge that our communities face, but we won't know whether interventions are effective unless we participate.
That's definitely very important. Thank you for that, Dr. Araneta. So I think a related question to that then is, on one of your slides, you show that thin Asian Americans accumulate more visceral fat compared to overweight African Americans. How and why do we accumulate more, and how do we get rid of it? So what kind of interventions should we be looking at?
That's a mystery that nobody knows. We don't know, and it also seems kind of unfair that, you know, you have a 26-inch waistline and you're loaded with visceral fat, and that visceral fat is an active endocrine organ and produces cytokines and inflammatory markers. The answer to that is still unknown. A lot of studies that have shown a reduction in visceral fat have only been conducted in obese individuals. So they've shown that exercising, that losing weight decreases visceral adiposity, but there hasn't been a study that have looked at those interventions in thin people. Then you also wonder, how would thin people be motivated to join a study to lose visceral fat? So we don't know.
Good question.
Are there any references to diet being a factor that's causing the increase in diabetes rate versus the other averages?
Most of the nutrition studies have been done in Asia, where and specifically in work settings where the workplace, especially factories, provide breakfast and lunch for their workers. And so some of the studies have shown that glucose levels seems to improve with brown rice versus white rice. Some studies have shown that eating the instant cup of noodles or ramen seems to increase your glucose levels. But I think these studies have to be performed in the United States because our environmental exposures and our behaviors in the U.S. are different from Asians in Asia. And our diets are as diverse as California's populations. We don't have traditional Asian food every day. And maybe even the sources of nutrients from food that's grown here might be different from food that's grown in Asia.
Okay. Thank you. I think, so there is a question about, is there any data on how the percentage of Asian Americans or Pacific Islanders living with diabetes, with undiagnosed diabetes, has changed since the Screen at 23 guidelines were released?
That's an excellent question. We don't know. We have no idea if these guidelines are being implemented. We would love to have that data from your clinics just to see if there's, what we would expect is an increase in the number of Asian Americans, at least with the Screen at 23 guidelines. We would expect an increase in diagnosed diabetes since 2015, but I don't have access to that kind of clinical data, so it would be great if we were able to pool all of our annual screening data for the last 3 years and to see if the Screen at 23 guidelines are in fact being implemented, and more importantly, are able to diagnose diabetes early among these patients to prevent the occurrence of diabetes complications.
Thank you for that. And and maybe this is geared towards Jeff and Jen as well as Dr. Araneta, but are you aware of providers screening at 23 for Asian Americans? And what would be a best practice to support them in implementing this?
I know some providers that are actually implementing Screen at 23. However, I am not familiar with them in our community health centers. So this is an area that I'm going to have to get more information about and get back to the conference participants.
Thank you, Jeff. And Dr. Araneta, can you talk about the increase in fatty liver in Asians that impact diabetes and how that impacts diabetes?
We didn't find excess hepatic liver in our Filipino cohort, nor was it observed in the MESA study. The MESA study is a multi-ethnic study of atherosclerosis, which includes a cohort of Chinese Americans in Los Angeles. The association with fatty liver so far seems to be limited to South Asians, and this was published by Dr. Alka Kanea who's the principal investigator of the Masala study. And so excess fat in the liver was independently associated with type 2 diabetes in her cohort, but we didn't see it in ours.
Thank you. And I think this question is geared towards Jeff, Jen, and Dr. Araneta, in that how can communities implement the Screen at 23 campaign recommendations, and are there resources out there for us to disseminate to our communities?
I think, so the Screen at 23 website, if you're able to share that if you haven't already, in the webinar package, has free resources. But I think it should not be limited to just the people, to healthcare providers. I think this is a great opportunity for community members, churches, temples, restaurants, festivals, to be engaged in the Screen at 23 campaign. Several years ago, San Francisco had a very effective and aggressive campaign on hepatitis vaccination. And I noticed that in billboards, in public transportation. And so I think every Asian American and Pacific Islander should be as informed about our risk for diabetes as African Americans are about sickle cell anemia. And so partnerships with grocery stores, restaurants, places of worship would yield a larger number of people who might not otherwise be screened if they're not seeing their doctors annually, or if they don't have access to health care. But I'm thinking of table tents that you could include in restaurants, or even information during worship services, and certainly during festivals.
Agreed. This is Jen. I just want to echo happy sentiments in terms of building community awareness. And I think what we can also do is APJA has partnered with the Diabetes Coalition and the National Council on Asian Pacific Islanders physicians on a Screen at 23 sort of infographic, which is, maybe a great resource. We'll sort of circulate to start the conversation, whether internally in your health center or with community partners to help raise awareness. So we'll make sure we send that out to everyone on the line.
Thank you. And just a comment from our participants for the question regarding who is currently screening. At Charles B. Wang in Community Health Center in New York, they are screening at 23, and also at the Center for Asian Health in New Jersey, screening at 23 as well. So awesome job, East Coast.
We'll be reaching out.
Okay.
Can I ask a question to those participants? What was the reaction of your patients when you mentioned that they should be screened at 23? Was there resistance or disbelief that they might be at risk?
Well, we'll be certain to share that comment. As of now, our webinar tool does not allow us to unmute everyone on the line. So for the response to your question, we'll share that with you once we receive it from the staff at the health center. With that, I am not seeing any more questions. If you have some burning last minute questions, please send them in. Okay, so the response, Happy, is that we tell them that it's a risk factor and that we are genetically predisposed and they are fine, and we are just seeing a lot of prediabetes in young and thin individuals.
Wow.
So that's the explanation that's given. And there is no resistance at all to the screening.
That's wonderful.
Thank you for sharing that.
Yeah, thank you. Thank you, guys.
Thank you, participants, for responding to Happy's question.
Okay, so any additional last-minute questions before? Okay, so seeing none, I would like to thank you, Jeff, Jen, and Happy for a great and super informative webinar today. Thank you to our participants for all your very thoughtful questions and also your comments and sharing your story. We will be sending out the slide deck as well as the recording and several resources that our presenters have mentioned after this webinar. And here is our contact information if you like to know more, if you like to connect with us on how we could think together on increasing screening at 23 for Asian Americans. We love to think with you. And with that, I'm going to close the webinar, and please, if you can, we're going to launch our post-webinar survey, and this will be really helpful to us as we think about ways that we could support you in doing your work on diabetes further. So thanks everyone for your time, and thank you again to our speakers.
Thank you, everyone.
Thanks. Bye.
Thank you.